too far. So yeah, so hopefully you've all started working on your final projects and you have a good idea of what you're doing. And as I've said, if you have any questions or you're not sure about what to do or whether or not something you're doing meets the requirements for the final projects, definitely don't hesitate to reach out to me and send me things or schedule an office hour to just discuss what you're working on. I've already had a couple of groups and individuals send me a few things to review. So far, what I've seen looks really great, and I'm excited to see all of your projects. But just make sure you're working on it, because I know this last 2 weeks of the semester is going to be really crazy with all of your projects for your other classes, your final exams, and other things going on. And on top of that, for many of you with graduation coming up at the end of the month. So don't hesitate to reach out if you need anything, and definitely stay on top of not only your final project. You also have the last 2 homework assignments. I've noticed most people have submitted homework number 4 at this point, and a few of you have also submitted homework number 5 as well. So just make sure you're working on those. I would recommend, just to kind of get it out of the way, that you try to get the homework assignments done this week. That would be ideal, so then you don't have to worry about them at the same time of working on your final project as well. And I'll leave some time at the end today, and I'll stay on for however long you all need me to. If anyone has any questions on homework number 4 or homework number 5, I can pull them up. We can kind of go through any questions you might have to make sure that you're able to complete those well. So, and then lastly, just make sure you're scheduling your last office hour with me if you haven't already. I've met with many of you, but I know there's many of you I haven't met with yet. So just make sure you schedule that sometime before the end of the semester. So before I move on, any questions, any concerns, any last minute things that you all need or have questions about at all?
So we later, something about the project. Can I just ask you about that later?
Or you can ask it later or now, either one. Yeah, right now it's totally fine.
Okay. Yeah, so for the infographics, I have a partner. Do you want that in the presentation as well, or do you just want to like separately?
It'd just be a separate sheet that you would submit along with your recordings.
Okay, cool. Thank you.
Yep, of course. Any other questions, concerns? Cool. Well, as I've always said, don't hesitate to reach out to me. You can text me, you can email me, just let me know what's going on. I want to make sure that you're all finishing out the semester strong, but I also know that this is typically the most stressful couple of weeks of the semester of the year, as you're kind of finishing up and trying to just get out of here, right? I mean, it's almost summer, and I know myself included, we're all just kind of ready for this virtual instruction to be over and to have a little bit of a break. So we're almost there, just a couple of more weeks. So hang on, let me know if you need anything, and do your best to just come out of this strong. So, all right, so a couple of things for today. So today we're going to talk about chronic disease and physical activity epidemiology. So I know this is going to be a little bit more in a lot of your wheelhouse in terms of what you're interested in and what might be related to, things that you're doing or that you want to do in the future in your careers. And so we'll talk a little bit about just chronic diseases, their impact on our society. We'll look at some of the data surrounding physical activity, and then we'll talk about some things around how do we promote physical activity. I know from having met with many of you or with all of you at this point in office hours that many of you are personal trainers, that you do a lot of stuff surrounding physical activity and health. And that is also part of your long-term goals, whether that's to be a physical therapist or someone working in the health field. A lot of that is how do we promote physical activity to promote health. And so this is kind of going to be a little bit of a general lecture about some of the data and then some of the strategies and how we've come up with guidelines and things that we use in public health to get people to be physically active. Because as you'll see in the data that I'll show you later, the number of people who are physically active in the United States is really low. And physical activity, as you all know, and as we'll discuss a little bit today, has a myriad of benefits for health and longevity for the population as a whole. So we need to do more to not only allow people the space and the time to be physically active, but also to provide the resources and education that they need to understand and be able to be physically active as well. So I did want to start out, I mentioned this last week at the beginning of class, that I had come across this tweet, and this was just tweeted out on April 26th, that is from WebMD, source of amazing information, right? Now, well, I mean, WebMD has some really great information, but there's also, it's one of those things where I'm sure all of us have done this, where you start to Google symptoms and you go from 0 to 1,000 immediately, and you're like, oh my gosh, I went from having a headache to I'm gonna die tomorrow. So we got to be really careful about how we use that type of information. And I'll be honest, I even did that after getting my head injury and getting the stitches. As I started to get black eyes, I was like, oh crap, I hope this doesn't turn into raccoon eyes and full black eyes, because that means I probably have a skull fracture and potentially might have a more serious injury than I thought I did. Luckily, that wasn't the case, but I'll admit, there was a moment where I was looking up things and like, oh crap, this could be way worse than I think it might be. Thankfully not. So they tweeted out, people who ate French fries or hash browns are 2 to 3 times a week are more likely to die early, according to one study. So what's the problem with this particular tweet, with this particular headline that WebMD tweeted out about a week and a half ago or so? Any thoughts, any ideas? What's wrong with this?
It's probably neglecting other factors that lead to like early mortality.
Yeah, so it's probably, and this is what we talked about 2 weeks ago and a little bit last week, it's probably neglecting a lot of confounders and other factors that can lead to early mortality. So here is a little excerpt from the abstract from the paper that was actually published in 2017. So I was actually uncertain as to why WebMD decided to post that tweet now when the paper was published 4 years ago. They did a cohort study and they looked at fried potato consumption, or just potato consumption in general, to see whether or not it was associated with mortality. There's a couple of problems with it. One of the problems being is that it's likely, or it is neglecting a lot of the other factors that could lead to early mortality, such as consuming other foods. So what do we often consume when we're eating like French fries or other fried potatoes, right? We're not consuming that typically with a salad and other healthy foods. Often it's with a burger or other foods that we would also consider to be unhealthy. So one, how do we tease out the potato consumption versus all of the other foods that are being consumed, not only at that same time, but also in that person's diet as a whole? If they're eating fried potatoes 3 times a week, what might that imply about their diet that they have the rest of the week? They may be eating salads for every other meal, or they may be also, eating hamburgers or fried foods or other things for every other meal as well. Those types of differences are nearly impossible to ascertain, even though what they say, a lot of the way that nutrition epidemiology and nutrition research is done is through what we call food frequency questionnaires. So essentially what that is, if you've never heard of a food frequency questionnaire, is we ask people a series of questions, and it's often really long lists of questions of how often do you consume potatoes? How often are those potatoes fried? How often do you drink milk? How often do you eat vegetables? And it's this kind of long laundry list of foods that people could potentially consume, and asking them how often they're consuming them. So as you can imagine, one potential or one large issue with this type of research is recall bias, which is bias in the way that people are going to remember what they ate in the past and how often they ate it. And especially when we're thinking about things that are undesirable foods that in our society that we say are often unhealthy, people are likely to underreport how much they eat. And we've seen that from laboratory studies where people will say, oh, this is what I eat on a daily basis, but often people don't report on their number of snacks. Or if you're drinking, for example, like tea, and you're asking about sugary sweetened beverages, if someone sweetens their tea, they're not going to consider that to be a sugary sweetened beverage, and they're going to probably omit the fact that they added 2 or 3 teaspoons or tablespoons of sugar into their tea, which contributes to a number of things as well. So there's a lot of issues with how we can ascertain information about people's diet that lead to bias in the results of the studies and in recall and social desirability responding and so on. The other issue with this study, and this is one that is pretty major in my opinion, is that they're attributing fried potato consumption to essentially all-cause mortality. So what does all-cause mortality mean? That means death for any reason. So that means that according to this study, somebody who eats fried potatoes 2 to 3 times a week might be more likely to die from a motor vehicle accident, or might be more likely to die from other accidental reasons or something. And as you can hopefully appreciate, that thought is absurd, that if you're eating more potatoes, you're more likely to die for any reason whatsoever. And that in reality, it's going to be from a specific number of health conditions that are related to poor nutrition and other behavioral health issues, such as poor physical activity and stuff. So that leads to, and this is something, if anybody's on Twitter, something that's been making rounds on Twitter recently is, all of this information we get, it comes from published literature, right? So researchers conduct research, we publish things in journals, and then that's disseminated, and sometimes that's picked up in the media, such as this fried potato consumption article. But one of the problems with nutrition science and nutritional epidemiology in general is that, as we've all seen and we've discussed a little bit in this class, is that because there's so many issues with the way that the research is conducted, with potential bias, potential confounding, that we see studies coming out, sometimes it seems monthly, but every couple of years or so, that'll say things like, coffee is good for you. Oh, wait, we forgot to adjust for a confounder. Whoopsies, coffee's now bad for you. Trial says coffee is actually good for you. And this might seem comical, but it's actually not that far away from the truth of what we've seen in the way that research on nutrition and diet has been reported in the media, where things like coffee, things like alcohol, salt consumption, egg consumption, we see articles and media articles pop up every so often that contradict each other, where one will say this food is good, the next one will say this food is bad. And what that does, and why I hate to see those types of things, is because that is very confusing for the public who's trying to take research and understand what that means for their own individual behaviors, and for policy development that's trying to make recommendations based on research to ensure that we're providing the right education and resources and information for the public to be able to live as healthy a life as possible. It also creates issues with trust in the research process as well, where people can use examples like this and say, well, see, the research isn't even definitive. How am I going to trust things about vaccinations when I see all of these contradictions that we've seen in research throughout all of this time? And so that sensationalization of research findings, that misreporting of research findings, and more than that, lack of understanding of how the research was even done in the first place and how it's reported in the media, that leads to significant issues in how we can interpret those findings and how research is trusted and used by the general public. So I always hate when I see these types of things in the media, because I just cringe, and I know that the studies probably had a lot of limitations that are not going to be talked about, and that these things are going to be shared on Facebook and Twitter and Instagram rampantly. And there's going to be a lot of misinformation that's really difficult to combat. And so we need to be mindful about how we're sharing that information. So hopefully all of you, having a little bit more knowledge about epidemiology and how research is conducted from this class, can take some of the things that we've learned. And when you see this, as I've said multiple times, go to your family, go to your friends, maybe not post on Facebook about it, just because I don't ever encourage getting in Facebook arguments about misinformation. They never go well in my in my experience. And so I tend to just not engage on social media because I don't want to invite in just crazy conversation, but at least be a voice of reason for your family and your friends and people who may be using information wrong or may not be understanding how the research is conducted or the field as a whole or whatever it might be. So this all leads into our objectives, and that is related nutritional epidemiology to chronic disease epidemiology and physical activity epidemiology, because often we talk about physical activity and nutrition together as a way of promoting health and advancing longevity of the population. So today we'll talk about objectives of chronic disease epi, describe what physical activity epidemiology is and some disparities, and how do we increase physical activity. So as you've seen already, and I've shown you a couple of times throughout the class, when we look at trends in morbidity and mortality in the United States, we've seen, with the exception of this last year and a half or so, a sharp decline in the number of deaths as a result of infectious diseases. And that's largely due to advancements in the way that we can detect infectious diseases and in the treatments that we have available, such as antibiotics and vaccinations, to prevent and treat infectious diseases as well. But at the same time that we've seen that sharp decline in the number of infectious diseases, not only in the United States, but globally, we've seen a sharp increase in the number of chronic diseases globally, and especially in the United States. And this, as I've mentioned before, is what we call the epidemiologic transition. And there's multiple stages of the epidemiologic transition that move from stage one, where we're looking at, and this is early 1900s and before, where malnutrition and infectious diseases were the leading cause of mortality and morbidity in the population globally. But as we've improved nutrition and we've improved public health and vaccinations and other things, that's led to an increase in chronic non-communicable diseases. And that's stage two. As we've continued through this transition, we've seen people become more sedentary, especially in their jobs, where earlier on, many jobs that the population was doing were very labor intensive. They were engaging in a lot of physical activity in their workplaces, and that had a lot of health benefits as a result of this, them just engaging in their work. But as a lot of our industries and work has become more sedentary, we've seen a reduction in physical activity, especially workplace physical activity. I know personally, I sit behind my computer most of the day, especially not being on campus. One thing I love about being at CSUSM, especially with all of the stairs, was that if I had to go to a meeting, I was at least getting some activity and steps in going up and down the stairs. Now my watch yells at me every hour to stand up, because there are some times where I don't stand up from my computer for 3 or 4 hours because I'm working and I just kind of forget. And so we've seen increase in fat and caloric intake, and the changes in the way that our food is produced and the types of foods that we're eating, moving it away from sustenance farming and small farms to large farms and large processed foods. And we've also seen an increase in tobacco use, and that surpassing of chronic diseases from infections and malnutrition. And now we're in this stage 4 in most developed countries of cardiovascular disease and cancer being the leading causes of morbidity and mortality. And we really are putting most of our efforts towards prevention and treatment of chronic diseases, with the exception of this last year or so, where we've put most of our efforts towards the prevention and treatment of COVID-19, while also still facing a large burden of chronic diseases and seeing a large number of people with chronic health conditions also dying from COVID-19, because those comorbid conditions exacerbate each other essentially, and people are more likely to have severe COVID-19 if they also have other chronic health conditions at the same time. So when we look at, in the United States, the leading causes of death, we see that heart disease is the number one, and this is 2018 is green, 2019 is blue, 2020 is red. And this is up to the most recent data that we have available, including 2020. So heart disease, cancer, those are the two leading causes of death. So those are chronic, what we'd consider chronic health conditions, non-communicable health conditions. And then we see things like stroke, chronic lower respiratory disease, Alzheimer's, diabetes, kidney disease, and so on. So the majority of death in the United States of mortality is as a result of non-communicable chronic diseases. We see in 2020, the third leading cause of death was COVID-19 in the United States. And I believe globally, it's around the second or third leading cause of death globally as a result of the number of people who have been infected with and have passed away from COVID-19. So this tells us, and what we all know is that the largest burden of disease in our population is from chronic diseases. And we can also separate that out by age group, because it's important that we don't just take data for face value and say, okay, the causes of death is the same for everyone in our population, but rather when we look at it by age group, we can see some differences where from ages 1 to 44, the leading cause of death is actually unintentional injury. And as people age, as we know, as we age, we're more likely to develop chronic health conditions such as cancer, such as diabetes, such as heart disease. So as we age, cancers and heart disease take over as a leading cause of death. And unfortunately, we also see in the younger age group, suicide being the second leading cause of death. Overall, it's the 10th leading cause of death in the United States. And one thing that's interesting that the data is currently showing is there was a large concern by people across the world that a lot of the measures that were taken to prevent COVID-19 would lead to an increase in suicidality and suicide death. But we've actually seen that the number of mortality from suicide has decreased. It decreased in 2020. Still trying to determine, kind of what was going on there, but that still shouldn't discount the fact that there are a large number of people facing mental health conditions like depression and anxiety as a result of the COVID-19 pandemic. But when we break out the leading causes of death by age group, we see that in general, for most age groups, we see very similar causes of death, just their ranking in the top 10 changes by age group overall. So there are currently over 117 million people living with a chronic disease. That accounts for about 6 in 10 adults in the United States, or over 1 in every 2 adults in the United States have some chronic health condition. And more shockingly, 4 in 10 adults have 2 or more chronic health conditions. So that what that might mean is that a person has heart disease and diabetes, or a person has cancer and some other chronic health condition. So we have over 15 million people with coronary heart disease, over 29 million people with diabetes, and over 13 million people who are living with cancer. And chronic diseases rank as 4 of the 5 most costly conditions in the United States. So when we think about cost of healthcare, cost of treatment, chronic conditions really up until 2020, where we've seen a lot of our cost of healthcare going towards COVID-19 prevention and treatment, chronic conditions really do cost a lot of money, billions and billions of dollars annually to both prevent and treat in our population. And one of the things that I want to do when we talk about chronic diseases, because oftentimes in the media, oftentimes in research, oftentimes in classes, when we talk about chronic diseases, we talk about them as individual problems, in that a person has diabetes because they weren't physically active enough, or because they had a poor diet, or because of some other factor. What I really hope for you all to leave from this class with is shifting away from thinking about disease, especially chronic diseases, as an individual problem, and thinking about it more as a societal and systematic problem, where if a person is not meeting physical activity guidelines, which we'll talk about in a minute, that's not always and often not even majority as a result of their individual decisions or behaviors, but rather there are multiple factors that can impede a person's ability to be physically active and to eat healthy and to engage in the behaviors or access the resources they need to prevent diabetes or other chronic diseases. And so when we think about chronic diseases as this multi-causation disease model that we've been talking about throughout the semester, what we really need to focus on if we want to improve the health of the population, if we want to increase levels of physical activity for the population, decrease overweight and obesity, and decrease chronic health conditions, we really need to focus on things like education, where everyone has access to good quality, adequate education, and education about the benefits of being physically active and eating healthy. You've probably all seen that in many areas, things like physical education programs in K through 12 schools are being minimized or eliminated completely, where kids are not getting PE in the same way that maybe, and some of you may have actually faced that, but I know when I was growing up, we had PE every single day for like an hour, and we were required to do a lot of different activities. That a lot of times even wasn't sufficient, because sometimes those activities meant like just standing around if you didn't want to participate. But in order to instill the value of being physically active, that needs to start at a young age, right? So we need kids to be engaged in physical activity. We need their parents to understand the benefits of physical activity and promote physical activity for their kids as well. And so they need to have the education and the tools in order to promote physical activity for their kids and have them value those behaviors throughout their lifetime. So as an anecdotal example, one thing that my husband and I do for our son is we go running, especially on weekends, and we have a running stroller, and we'll go running with him in the stroller so he sees us being physically active. We go hiking with our hiking backpack, and we have him in the back and we carry him. And there's research that shows that kids seeing their families being physically active actually promotes those behaviors and makes them want to engage in similar behaviors as they grow up themselves. And so that's what we need to do, is provide opportunities for more families to be able to engage in those types of behaviors through providing safe neighborhoods, through providing safe housing, through providing the education about those. If we want people to eat healthier, then we need to ensure that they have access to affordable, healthy foods, and that they know how to prepare those healthy foods, right? It's not enough to just say, eat more vegetables, because if someone's never incorporated vegetables in a meaningful way in their diet, then they're gonna get vegetables, they're not gonna like them, or their kids are not gonna eat them because it doesn't taste good to them. And so then they're either not gonna eat, or they're gonna revert back to the foods that they know that taste better to them. So it's not about just access to those healthy foods. They need to be affordable, they need to be available in their neighborhoods, but it's also about educating people about how do you prepare them in ways that you're going to want to eat, that your family is going to want to eat. And if you think about too, from a cultural standpoint, in many cultures, food is very ingrained in the culture, and the types of foods that they prepare and that they eat is a part of their family, it's a part of their culture and their livelihood. And sometimes those foods aren't what we would consider the healthiest of foods. So how do we incorporate in healthy foods and things so that they can not only have those foods that are important to them culturally and in their family, but also eat healthier as well. So if we want to improve people's health as a whole, improve their physical activity levels, improve their diet, improve their longevity, then we need to address all of these structural things and address things that people have access to and that they can afford and that they have knowledge about. It's not just about saying, be physically active. We know from research, most research to promote physical activity or to improve diet is not effective, meaning that they'll conduct research studies and say, go out and eat, I'm going to give you all these resources. You're going to eat healthier in this research study. You're going to be active. They might work for a short period of time, but once somebody's no longer in that environment where they have all that support, where they have all those resources that are given to them as part of the study, most people revert back to what they were doing before they participated. You've probably all seen, there's the TV show, The Biggest Loser, where they followed those contestants who lost a lot of weight on that TV show, and have found that actually a large number of those contestants actually reverted back to their weight before the show. And some of them actually gained even more weight than they had before the show. And that's just another demonstration that those short-term focuses on, let's engage in this high intensity activity in a short bout of time, and let's also give you access to all the foods and things that you need. They're effective in that confined environment. But once you're out of that environment and someone doesn't have that level of support, those things are no longer effective. So we need to develop tools and systems that can have sustainability over a long period of time. So one of the things that we talk about in public health is what we call the 3-4-50 concept. And that 3-4-50 concept is that 3 behaviors: poor nutrition, physical inactivity, and tobacco use, or smoking cigarettes really, lead to 4 chronic diseases, which are heart disease, stroke, cancer, diabetes, and pulmonary respiratory diseases that lead to over 50% of deaths in our population. So if we specifically focus on these 3 behaviors, we would not only reduce the rate of mortality in the population, we would also increase the lifespan of our population and the quality of life of our population as a whole. We've made great strides in reducing rates of tobacco use in our population. And now when you compare it to 30 or 40 years ago, rates of tobacco use are about a quarter of what they used to be. But there's still a lot of work that needs to be done to reduce those rates even lower. And as we've advanced in our knowledge of the effects of tobacco and smoke on health, we've also seen that even if a person's not smoking, that secondhand smoke exposure, that is associated with a number of health outcomes, and that even third-hand smoke exposure is also associated with a number of health outcomes. And what third-hand smoke exposure means is that, say, somebody smokes in an indoor building, smoke is really can penetrate a lot of surfaces. The soot and all the contaminants in the smoke can accumulate on clothing, it can accumulate on furniture, it can accumulate in paint, and so on. And so even just going into a space where people were smoking and touching those surfaces and then breathing in and touching your hands to your mouth, that's actually associated with a number of health outcomes and strong things like developing of lung cancer and stuff, because you're still being exposed to those contaminants and things that are in cigarettes and other tobacco products that can lead to adverse health outcomes. So we need to get better messaging out about that, right? Where if you have, for example, a family member who smokes, that even just hugging them and coming into contact with their clothes on a regular basis, even if you don't smoke and they're not smoking around you, that still has implications for your health as well. So then when we look at we looked at those leading causes of death, and we see that they were mostly chronic diseases. If we look at the actual causes of death, so what are the underlying things or behaviors that are leading to higher rates of mortality in our population? Those are things like tobacco use, poor diet and physical inactivity, alcohol consumption, microbial and toxic agents, motor vehicle crashes, and that leads to unintentional injuries, firearms, sexual behaviors as a result of spreading of infectious diseases, and illicit drug use. And what we see specifically when you look at that poor diet and physical inactivity, and again, these are all things that hopefully most of you know and have learned about, but sedentary lifestyles increase all causes of mortality. They double the risk of cardiovascular disease, diabetes, and obesity, and increase the risk of colon cancer, high blood pressure, osteoporosis, lipid disorders, depression, and anxiety, among other things. And there's an estimated over 300,000 deaths annually that are specifically due to physical inactivity and poor diets. So what's physical activity? You all know this. Physical activity encompasses a myriad of behaviors, including things like exercise, occupational activity, gardening, yard work, household chores. It's any level of activity that kind of gets your heart pumping, gets you moving, that has some kind of health benefits overall. One of the things that we've shifted towards in a lot of our research, especially in public health, is not just physical activity and how do we get people to be more physically active and continue to engage in more physical activity, but on the flip side, how do we reduce physical inactivity and sedentary behavior? Because what we've seen, especially as most of our workplaces, most of what we do in school, you all sitting on Zoom right now, that is sedentary behavior or physical inactivity. And we've seen that even when people are physically active and meeting the physical activities guidelines, that if they have the rest of the day, they're sitting down and doing nothing and being physically inactive or sedentary, that's actually also associated with a few health outcomes as well. And so we need to not just improve physical activity levels, but reduce the amount of sitting and inactivity levels that people have. So physical inactivity means insufficient physical activity levels to meet present physical activity recommendations. Sedentary behavior means any waking behavior that's characterized by low energy expenditure. So that's meaning sitting, reclining, or lying down, which most of us do for large periods of our day, unfortunately. So what's total energy expenditure, and how do we measure how much we're being physically active? Hopefully you've all seen this if you've taken things like KINE 326 and some of the other kinesiology classes. But basically, depending on how active you're being, from things like running to walking to sitting, we can equate how active we're being to what we call metabolic equivalence. That's essentially the amount of energy that we're expending. And this is really boiling it down to very, very basic level. And so there's a lot of things that are incorporated into our total energy expenditure. That includes just our variable activities throughout the day. That includes our activities of daily living, like showering, walking around, things like that. The thermic effect of food, eating food, our body has to produce that. We expend energy doing that. And our basal metabolic rate, which is essentially the amount of energy that we expend just to be alive on a daily basis. So what are the things that impact our energy balance and our total metabolic equivalence on a daily living? At the very basic level, and I know many of you will probably say, well, it's way more complicated than this. And it is way more complicated than this. But at the very basic level, energy intake, energy expenditure, if we want to balance that out, maintain a healthy weight, maintain healthy lifestyles, we want to balance out the amount of basically calories in, calories out that we're expending. And that boils it down to the very basic level. And I know there's a lot of diets out there. There's a lot of things about food quality and a lot of stuff that talks about how do we actually measure these things. But when you really boil it down to most of the science, it's about how much you're eating and about how much energy that you're expending when we're looking at that energy balance as a whole. It gets a lot more complicated than that. And I know you can't actually see what's incorporated in most of these boxes, but in the middle here is energy balance. And this is all of the things surrounding it, is everything that impacts energy balance in the population or in an individual. And so just to kind of demonstrate what these different factors are, there are things like our biology, our genetics that can impact energy balance, our activity environment. Do we live in safe neighborhoods? Do we live in areas where we can go out and walk or run or be physically active? What are our individual activity levels? Those are going to be influenced by our activity environment. Individual psychology, our motivation, our desire to do different things. Those are going to impact our individual activity and our energy balance. What foods we consume. But as we've mentioned earlier on in the semester, the foods that we consume individually, those aren't, while we make decisions when we're at the grocery store and when we're eating, those decisions, whether or not we realize it, are often influenced by food production practices and food marketing practices and food availability and food costs and all of those things that can impact our individual behaviors of food consumption. And a lot of that is influenced by the society that surrounds us and then the environments that we live in. So for example, in many neighborhoods, including in San Diego County, they live in what are called food deserts. And what a food desert is an area where there is limited availability of grocery stores. And what they have more is they have mini markets like liquor stores, and they have fast food restaurants. So that means the food that's most readily available to people in those neighborhoods is what we would consider processed and unhealthy food. And so that availability of those foods and that limited access to other healthier foods contributes to what people in those areas are consuming on a daily basis and contribute to their overall energy balance. So again, it's not just about focusing on individual behaviors, but it's about focusing on the environments and the societies that we live in and all of those things that can impact our individual energy balance, because the behaviors that we engage in are affected by the things that surround us on a daily basis, whether or not we specifically recognize it and acknowledge it on a daily basis. So physical activity, when we talk about the epidemiology of physical activity, less than half of adults get the physical activity they need to help reduce and prevent chronic diseases. 53.1% of adults in the United States meet aerobic physical activity guidelines, but only 23.5% of adults meet both the aerobic and muscle strengthening guidelines. And it's estimated that about $117 billion in annual healthcare costs are associated with just inadequate physical activity levels. And that's as a result of the development of chronic diseases and other health outcomes as a result of sedentary behavior and physical inactivity. And there's been a lot of research that we've based all of this on. And so this is just going to be me quickly going through some papers that have shown the long-term effects of physical activity on cardiovascular disease, long-term effects of reducing sedentary behavior, even in the absence of large levels of physical activity, on reducing cardiovascular disease. There's been an emerging field of research on physical activity in cancer, where physical activity is not only shown to prevent a number of cancer outcomes and lower cancer incidence as a whole, but even among those with cancer who are undergoing things like chemotherapy and radiation, being physically active during those treatments actually has been shown to improve the outcomes of those treatments as a whole. And so physical activity plays an important role in not only cancer prevention, but also cancer treatment. We've seen that increased television viewing increases cardiovascular disease, that there are a number of things related with sedentary behavior, physical activity, and stroke. But one of the things that I want to move away from as well, because oftentimes when we think of physical activity, what we most often frame it around to the public is in reducing weight. And there are a number of health outcomes that are associated with overweight and obesity, but there's also a large emerging field of research that shows that physical activity has long-term health benefits regardless of a person's weight status. And that a lot of times it's not necessarily just overweight obesity as we normally measure it using BMI, which I'll talk about some of the more problems with BMI in a moment, but it's body fat distribution and body fat composition as a whole, and the types of fat that a person has that are associated with long-term health outcomes. So we need to shift away from that be physically active to reduce your weight to be physically active because it has a number of benefits for your health in these ways. And if we reframe it in that way, it might encourage more people to be more physically active. And we've seen that in some of the research that's been done. And so more recently, even with COVID-19, there's been a lot of research that's shown that people who are more physically active, that they're actually less likely to have severe COVID-19 outcomes. And that physical inactivity, so people who are largely sedentary, are more likely to face severe COVID-19 as a whole. So even with a lot of infectious diseases, physical activity can help with reducing severe health outcomes in the population as a whole. So what are the physical activity guidelines? So in the United States, and hopefully you all know this, I know you've heard this in many of your classes, Recommendations are that for substantial health benefits, adults should do at least 150 minutes a week of moderate intensity or 75 minutes a week of vigorous intensity aerobic physical activity, or a combination of the two, and that people should also engage in muscle strengthening activities of at least 2 or more days a week, because there are additional benefits to muscle strengthening activities, especially as we age. So those are the guidelines that we have in the United States. These are the same for adults and older adults, but the recommendations change slightly as people age, where the goal is for them to meet this recommendation. But if people are frail or in poor health, it's really getting any activity that they can. And at younger ages, the recommendations are slightly different, but in general, it's be as physically active as you can at younger ages. But how do we develop those physical activity guidelines? So the first set of physical activity guidelines in the United States came out in 2008. And those were developed based on doing systematic long-term reviews of the research and the literature on the benefits of physical activity and health. So there was a committee put together by Health and Human Services of the United States and the Centers for Disease and Control of Prevention that was tasked specifically with going through all of the research that's been conducted on physical activity and health and examining the quality of that research, the evidence that it provides for the benefits of physical activity and health, and synthesizing that into recommendations for, as people are more physically active, how does that benefit their health as a whole? And initially, when the recommendations were developed in 2008, the recommendations were pretty strict in that in order to get benefits from physical activity, you had to engage in a certain level of physical activity and that it had to be sustained over time and so on. And they wrote an over 650-page report summarizing all of the science surrounding physical activity and health. And that was used to develop those guidelines that I just showed you. That was also used to develop health education materials for the population as a whole. Since then, those recommendations have been revised. There was first revision to develop strategies to increase physical activity, especially among youth, as evidence emerged that as youth got engaged in physical activity younger and younger, that they were more likely to engage in physical activity throughout their life. And then most recently in 2018, the recommendations were revised again to change the specific recommendations for youth, adults, and older adults. So what do those recommendations look like and how have those changed? The main changes to those recommendations, and I'll show you a slide on this, is that really any level of physical activity is good. It used to be that the physical activity guidelines said that unless you were active for at least 10 minutes at a time, that any level of activity lower than that didn't actually count towards your meeting those physical activity guidelines. But the new guidelines say that even if you're active for a minute or 2 minutes, that still counts towards your 150 minutes a week or 75 minutes of vigorous activity that are recommended towards meeting those goals to have substantial health benefits from being physically active. So what that has recognized is that the emerging level of research that's showing that just doing something, even if that's just walking around slowly, that has health benefits, and that the more that we do that, the more health benefits that we're going to get from being physically active as a whole. So let's talk a little bit about what the epidemiology of physical activity looks like in the United States. So I'm going to show you some figures and just to orient you to these a little bit. On the left, this is the percent of the population engaging in these activities. This is over time. And what the blue is people in the population in the United States who met both aerobic and muscle strengthening guidelines. So that's that 150 minutes or 75 minutes of vigorous or moderate activity and at least 2 days a week of muscle strengthening. And then the red is met neither of those. So if we look starting back in 1998, up until when this data was available, which is 2006, we actually see that the number of people who meeting both of the levels of physical activity, that's increased slightly, but it's still only sitting around 23–24% of people currently meeting the guidelines. And the number of people who are meeting neither of them has decreased slightly, but still almost half the population is meeting neither the aerobic or muscle strengthening guidelines. We can also separate out this data by age, where if we look, the younger age group is less likely to meet neither and more likely to meet both the strength aerobic and muscle strengthening guidelines. And that as people age, we expect this a little bit, but only 10% of the population, or less than 10% of the population, 75 and older, about 15% of the population between the ages of 65 and 75 are meeting physical activity guidelines set forth to have substantial health benefits. So that's problematic in many ways, right? And so we need to come up with strategies for older adults to be physically active, because there are huge disparities in being able to meet those guidelines to have health benefits. We also see disparities by race ethnicity, where we see that Black, American Indian, and Hispanic Latino populations are more likely to meet neither of the guidelines, and they're less likely to meet both of the guidelines. So again, this just points to problematic issues with how we promote and allow communities of color to engage in physical activity, especially because many communities of color are in unsafe neighborhoods, have low socioeconomic status, and face a lot of systematic barriers and discrimination and other things that impede their ability to be physically active. So we need to change those environments. We need to change those systems, starting with our education system, to promote physical activity at a young age and change the environments that people live in so they have access to more parks and areas where they can be physically active on a regular basis. We also see differences in physical activity levels by education, where people with lower education are less likely to meet the guidelines and more likely to not meet either aerobic or muscle strengthening guidelines. So again, we see that correlation between higher education, more participation in physical activity as a whole. And then what we see as well by looking at poverty levels or by income, that people who are in lower income brackets, so this basically, this 400% or more, that's one of the lowest income brackets that we have in the United States. Meaning that people are well below the federal poverty level, that they're less likely to meet both guidelines and much more likely to engage, much less likely to engage in physical activity as a whole. So let's look at this in the distribution of the population as well. If we think about epidemiology, when we look at who's being physically active across the United States, we see that in the West and in the East, that people are more likely to be physically active with these blue colors, meaning higher levels of physical activity. Some of this can be attributed to, I don't know why my slides keep switching back and forth, I apologize. Some of this can be attributed to better environments and environments where physical activity is promoted. So we're fortunate, we live in San Diego County, where we can be active outdoors almost every single day of the year, and that we live in a really great climate and in an area where physical activity is promoted and where the environment is built to allow people to be physically active. More and more, we see more bike lanes being built so people can commute, though if you don't live close to work, commuting in San Diego via bike or being physically active can be challenging. One of the things that we have going against us, though, say in San Diego County versus New York City, is our public transportation is really poor. And if we want to think about ways to engage people in being physically active, a great way for people to be physically active is to use public transportation to get to and from work, because that requires them to walk to the public transportation, to walk to work and get that level of physical activity regularly as part of their normal daily routine, as opposed to having to fit it in outside of that. In San Diego County, if I wanted to, so I live in Mira Mesa, if I wanted to take public transportation to get to Cal State San Marcos, it'd probably take me about an hour and a half. And I just don't have that amount of time to be able to take public transportation to get to Cal State San Marcos when I'm in an in-person environment. So that's problematic. We've also seen with the COVID-19 pandemic as well, that it's kind of been this double-edged sword, right? For some people, it's actually increased their physical activity because they have lower commute times, they have more time to do things on their own, and so they're engaging in more physical activity. For other people, it's reduced physical activity because we've also closed down gyms and we've reduced people's availability to different places where they can be physically active. And so that's lowered their physical activity in many ways. And so we've seen, that kind of as a mixed bag for some people where they've reported higher levels of activity, other people that have reported lower levels of activity as a result of the pandemic. We can also overlay this, and again, this BMI data, it can be problematic, but this is what the CDC uses to examine obesity in the United States at the population level. And at the population level, what we see is when we compare where people are being physically active to where we see rates of obesity, we see that there's higher rates of obesity in levels where there's in places where there's lower rates of physical activity. This, again, this is just an ecological look at this data. And as you know from this class, what we can't do is say that those people who are being physically inactive are the same people who are overweight or obese in those same areas. But this gives us a picture of what that looks like so that we can go into those neighborhoods and go into those communities and further examine what's going on to develop programs to improve health of the population as a whole. But as I mentioned, and one thing that we use in public health a lot, and it's pretty controversial, and you all know, being in kinesiology and having taken some labs, and we talked about this a little bit, BMI is a really limited measure for many reasons. It's not even a good measure of overweight or obesity, let alone a good measure of health. And ideally, what we would rather use is body composition and have people's body fat distribution and total body fat percent measured by things like DEXA, by the bod pod, by hydrostatic weighing, and so on, because those give us a better picture of body fat distribution and its relation to health. But what becomes problematic about that is it's difficult to get a large number of people to be able to use those tools to measure their body fat percent. But BMI, at the population level, can at least tell us trends. If we're looking at BMI, even though it's terrible for individual health, at the population, it can tell us this is what we're kind of seeing in terms of overweight or obesity. But BMI was never actually developed to be used a marker of individual health and to be used in a medical setting to tell people about their health status as a whole, despite the fact that today, and probably many of us, when we go to the doctor, when I went to the ER for my cut on my head, they took my weight and my height and they told me my BMI. And if it was a BMI that they would consider to be overweight or obese, they probably would have said something about that as well. And this is often done in medical settings where people are told, oh, well, your BMI indicates that you're overweight or obese, so you need to be more physically active or eat healthy or do these things. But BMI as a tool is inherently racist and sexist for many different reasons. And it's as a result of how it was actually developed. So it was initially called Quetelet's Index, and it was invented over 200 years ago. It was derived solely from French and Scottish participants. So meaning that there were no people of color who were included in the development of the calculation to measure a person's BMI. And so what that means is that for communities of color, Black people, Indigenous people, Asian communities, that BMI overestimates in some communities their health risks. So for example, for Black communities, BMI actually overestimates fatness and health risk from overweight or obesity. And that's as a result of body fat composition and the types of fat. Where higher weights, in higher weight categories, Black people actually have lower levels of visceral adipose tissue, which is the type of fat that surrounds our organs that is very hormonally active and associated with a number of chronic health conditions, and are more likely to have higher levels of subcutaneous fat, which is the fat that surrounds our, is underneath our skin. And so that actually at higher weight status, Black communities have lower risk of heart disease, of diabetes, and a number of other chronic health conditions, despite still being told today by doctors that their weight is putting them at risk for a number of health conditions, even though the science is actually often not showing that same association. And it's really as a result of the types of fat distributions that we have. For Asian communities, BMI actually underestimates health risks, where in many Asian communities, when we see women, especially a lot of the research has been in women, when we see women who have what would be seemingly we would call a normal BMI, so between 18 and 24, they would actually be told by their doctor, your BMI is great, you have no health risks. But when you look at body fat distribution, the types of fat, at lower weight, Asian women especially have higher levels of visceral adipose tissue and lower levels of subcutaneous fat. And that visceral adipose tissue is associated with high rates of type 2 diabetes in Asian communities. And we've seen that, and I showed you some of that data earlier on, where there's specific Asian communities that have some of the highest rates of type 2 diabetes in the United States and globally, despite what we say having the lower body mass index and lower health risk as a result of that. And that's because they're missing a lot of these, doctors are missing these underlying fat distribution and health risks for things like type 2 diabetes. So as I mentioned, BMI was never intended to be a measure of individual body fat, build, or health. It was intended to actually be a measure of just the population as a whole, so we can look at trends quickly to understand how the population trends are changing, to be able to look at statistics and then allocate resources and do further research on what's going on. And so our over-reliance on things like that BMI, especially still today in our medical system, creates a lot of health disparities and health issues in our population. And so if you ever go to the doctor and they tell you something about your BMI and make recommendations about it, I would actually encourage you to push back a little bit and say, well, BMI is not a very great measure of health, and there's a lot of issues with it, because that's unfortunately still not part of the education in medical school right now. And so oftentimes doctors aren't aware of the issues with these types of things. And unfortunately too, there's a lot of misuse of research in medical school. So a lot of myths that perpetuate in the medical system, a lot of old science that's perpetuated in the medical system about a lot of things. So for example, when I went to get my stitches out yesterday, the nurse that was taking them out was telling me, oh, you need to keep your cut dry, because I've been keeping Aquaphor on it and Vaseline and other things to keep it moist, at the recommendation of actually my dermatologist that I go to, who said in order to reduce scarring, so you don't have a huge scar in the middle of your forehead, you want to keep your cut moist. And there's a lot of research that shows that keeping cuts moist actually reduces scarring and increases healing. But my nurse was actually telling me the complete opposite thing, where she was saying, oh, you're keeping it too moist, you need to dry it out, it has to stay dry, otherwise it's never going to heal. And that is actually, if you look back on the research 10, 15, 20 years ago, the recommendation was that cuts need to stay dry and that scabbing and those types of things help with healing, but those have shifted based on new evidence and science in terms of how the healing process works and reduction of scarring. Of course, it might vary from the type of cut and the depth of the cut and things like that, but that's where continual education and things are important for understanding health and long-term things in our population, because oftentimes doctors aren't at the forefront of the science and the knowledge that we have in order to educate communities properly about things that affect their health, especially things like physical activity and nutrition. Often we'll go to our doctors to ask them about nutritional advice. Doctors get like a 1 week, or many doctors. There are doctors who are specifically trained in nutrition that we can go to, but general physicians, family physicians, they often will get like a 1 or 2 week block of nutrition. So they're not always the right people to go to ask about certain advice, but it's who we often trust in our society because of that's just what we know and where we're used to going for different advice about our health. So getting back onto that was a little tangent, getting back onto physical activity epidemiology. Being physically active can prevent 1 in 10 premature deaths, 1 in 8 cases of breast cancer, 1 in 8 cases of colorectal cancer, 1 in 12 cases of diabetes, and 1 in 15 cases of heart disease. And why aren't these numbers higher? And a large part of that is the multi-causal factors that influence chronic diseases that we've talked about, in that physical activity is just one piece of the pie that leads to different chronic health outcomes. And as I mentioned, any activity counts. There's no lower threshold at this point for benefits from physical activity. Most of those long-term and substantial benefits occur with higher levels, but a lot of benefits from being physically active are immediate. And one of the problems, though, is that in order to continue to have benefits from physical activity and eating well, it's a lifelong behavior. It's not something that you can do in your 20s and then say, great, I was super physically active for 10 years. I'm going to be healthy for the rest of my life. It's something that we have to engage in our whole lives. And what's the problem with that is there's a lot of things that can both positively and negatively impact physical activity. Things that positively impact physical activity are things like education and higher income. Other things are like enjoyment of exercise, expectation of benefits, history of physical activity, social support. Social support's a really big one. And that if we have peers and family members and physical activity is valued, that we're more likely to be physical active. Enjoyable scenery, having safe neighborhoods, that's a big structural one, where people who live in safe neighborhoods, they're more likely to be physically active. If you have parks, if you have places where you can go and be physically active. Things that negatively impact physical activity: advancing age, low income, rural residency, lack of time and motivation. Though those are often talked about by people as being impediments to physical activity. Lack of time and motivation is typically as a result of other structural things, like that lack of time results from a person working 2 or 3 jobs and taking care of their kids as a single parent or other things. So it's really not the lack of time. That lack of time is a result of these other things that are impacting that person's life. The perception of poor health, being disabled. In many areas, we don't have places where people who are disabled have the ability to be physically active. So that creates large issues for disparities in chronic health outcomes among people who are disabled. Living in unsafe neighborhoods, perceived cost, and discrimination. And discrimination can come in many forms, whether that is through just being discriminatory while somebody's at the gym or in the neighborhood in general, or through being discriminated against on a daily basis for many different reasons. And so these are all things that we need to take into account. And in order for people to be able to engage in physical activity, they need to be able to have access to neighborhoods that they can be physically active in, access to gyms and places that they can engage in physical activity. They need to have access to education to teach them about the benefits of physical activity and ways in which they can be physically active, and so on. And unless we address all of those factors, we're not going to improve the rates of physical activity in our population. So how do we promote physical activity? There's a number of things that we can do. We can promote it through healthcare systems by ensuring that doctors and things like physical therapists, even dentists in some areas where they've done some research to show that if a dentist talks about the benefits of physical activity, that people are more likely to be physically active. So integrating knowledge and education about physical activity into our healthcare system can be an important way to promote physical activity. Integrating it into our businesses and into our industries, where right now, majority of people in the United States have very sedentary jobs, and we sit behind desks a lot of times. So how do we actually promote physical activity in the workplace and get people to be active? One strategy that some companies use is things like walking meetings, where you, instead of sitting at a conference room, you go on a walk and you have a meeting. Things like having gyms at the workplace where people are given time to go and be physically active during their workday, or having small breaks and promoting people to stand up and get up from their computer, where maybe it's that every hour, employees are encouraged to get up and do, 10 jumping jacks and 10 push-ups or run in place or something. And that all adds to their levels of physical activity. Developing better parks, recreation centers, fitness centers, and so on. Providing better education. For communities in color, one important place that we've seen to help improve health as a whole and promote physical activity and good diet is faith-based settings, where there's a lot of work to actually incorporate healthy behaviors and education into churches and other faith-based settings, so that people are seeing those messages coming from people that they trust and from places that they go to on a regular basis. Promoting sports. Oh yeah, go ahead, Trent.
Yeah, out of curiosity, like parks and stuff, because I know that like I enjoy going down the street to the park, doing like pull-ups and stuff like that. I wonder if neighborhoods with better funded parks might actually have lower levels of like obesity, diabetes, things like that. Like when you have like better like chances to go and exercise, is something like that.
We actually see that in the data, that in areas where there's more parks and better parks and clean parks that are safe for people to go to, that have those things like those workout areas, that actually there are lower levels of obesity, lower levels of chronic diseases, and so on. And so it really is about changing the environment that people live in to allow them to be physically active on a regular basis.
Yeah, that's awesome.
Promoting sports through mass media. So how do we promote physical activity in the media and so on? How do we talk about it? And one thing that really needs to shift, and maybe it's my next slide. I know that's, I'll talk about this in just a second. One thing that really needs to shift in the way that we talk about physical activity and promotion of physical activity is that oftentimes when we discuss physical activity, it's at the same time that we discuss losing weight. So be physically active so you can lose weight, right? Be physically active so that you can look better, so that you can have a beach body, so that you're ready for the summer. And this is a lot of the messaging that we see in commercials, that we see on TV, that we see in the media, and so on. But we already know that that messaging doesn't work, and that messaging is really discriminatory and exclusionary, and that it doesn't actually focus on the major benefits of physical activity in terms of chronic disease prevention and long-term health. And so really we need to shift away the messaging for physical activity away from losing weight to the overall health benefits of physical activity as a whole, so that we can engage more people in the messaging and not be discriminatory in the way that we talk about different things. Another big focus, a lot of the promotion of physical activity and public health as a whole has been in increasing physical activity in their leisure, like what we call leisure time physical activity. And leisure time physical activity is activity that we do when we're not working, and that's not, and in times it's not required of us. So what that means is that what we're trying to do is when you're at home, when you're not working, be more physically active. But what that does is, in this article kind of highlights some of those things, is that privileges the privileged, or the people who are high income, and there's a couple of vignettes here that you can quickly read through if you want. Or the first one says, a high earning professional living in a leafy suburb with stay-at-home partner and safe access to a well-equipped gym, who easily finds opportunities to exercise after work and enjoys being active after sitting at work for much of the day, compared to a single parent looking after 2 young children and working 3 low-wage jobs, who is living in a small studio in an apartment block where it's unsafe to go outside after dark, and who has limited opportunities to exercise. So now, if we're promoting leisure time physical activity to this single parent compared to this high-earning professional, hopefully you can see the disparities and the ability of those people to be physically active, their willingness to be physically active, their motivation to be physically active, and all of those factors that are going to change how one person's physically active versus another. So we need to think about all of those things in our messaging and how we're getting people to be physically active as a whole. So to kind of wrap all of this up, what's the purpose of physical activity epidemiology, of chronic disease epidemiology? With all epidemiology, big part of it is to quantify the magnitude of the problem. How many people are being physically active? Why aren't they being physically active? What are the things associated with low levels of physical activity and high levels of physical activity? And then how can we use this research and this guidance to promote public health resources and guidelines and prevention tools, such as the physical activity guidelines that we currently have? And then more than that, how do we monitor the effectiveness of these prevention programs that we've developed? What I'll tell you is what we know right now is most physical activity programs that are designed to increase physical activity levels and improve the health of the population have largely been ineffective at a large scale, meaning beyond what's done in the research, beyond what's done and what's beneficial for a small number of people. We haven't made great strides in improving physical activity, improving diet, and preventing chronic health conditions in the population. And we continue to see every year higher and higher burden of chronic health conditions. So what that means is we need to do more, and not just more at the individual level to tell people to be physically active, especially leisure time physical activity, but more at the structural level to create environments and systems and places where people have the ability to be physically active because they have safe neighborhoods and parks that they can go to, because they can afford to go to gyms if they want to, because they can afford healthy access to food if they want to. More than that, we need to ensure that people have the knowledge and tools provided to them by the education system, and that people have equitable access to education to understand the benefits of long-term physical activity, and so that they want to engage in those activities. And so we really need to be able to shift the way that we talk about things. And what I always tell students, because being an epidemiologist and someone who works in communities in my work, as opposed to a lot of the work that's done in kinesiology that's meant to promote the best performance possible. Let's get people to be as strong as they can. Let's people to run as fast as they can. Let's people to be the most athletic they can. That's great. And that's wonderful for a small number of people in our population. What I always say is, I don't really care how strong a person is. I care that a person is getting out and doing something, anything that can benefit their health as a whole. If that means that they're going out and walking for 20 minutes a day, and that was double what they did before or triple what they did before, that's going to have some long-term health benefit. Are they going to be able to run the fastest or lift the heaviest weights? No, but that doesn't matter when we're talking about prevention of long-term health outcomes and promotion of health in the population as a whole. So my focus and the focus of public health as a whole is what strategies can we develop to engage the most amount of people in these activities to improve the health of the population as a whole. And more than that, how do we do so in an equitable manner? So how do we make sure that all people, not just those who are high income or who have certain jobs or who have certain access to resources, have the ability to engage in behaviors that we know will benefit their long-term health individually and the health of their communities, and improve the status of the United States as a whole in terms of health and longevity. So there's a lot of things that we can do, but right now, so much of what we do focuses on individual behaviors and doesn't think about those larger structural factors that impede a person's ability to be physically inactive or physically active. So that's what I want you all to think about. Even if you're a trainer and you're working with people individually, how can you work with people to promote long-term health and well-being? And I know, that sometimes goes against like that individual. You have to have clients, and that's your livelihood, right? So you don't want people to, you want to teach people to go and be on their own, and you don't have any clients, but that's our ultimate goal. And one of the things that one of my advisors always said, and what I always hope for too, is I did a lot of, in my graduate work, I was and I still do some of this, an HIV researcher. And the goal for HIV has always been eradication. Let's get rid of HIV transmission in the population. And one of my advisors always said it best, is that her goal is to put herself out of a job, meaning that her research and the work that she does collaboratively with others across the globe is working towards completely eradicating HIV transmission so that she no longer has to do research on HIV anymore, because it's not a problem that we're facing at a large scale in the population. And so that should be all of our goal when we think about physical activity promotion, when we think about chronic disease prevention, and that we want to put ourselves out of our jobs, because that means that we're doing the right things to promote behaviors and access to things that people need to be healthy. But it's going to take a long time and a lot of change for us to get there. So what questions do you have, or anything that you're curious about? And then what I can do is, as I said, if anyone wants to stay on and has questions about the homework, I'm happy to stay around for however long you all want to, and go over homework or any questions that you have. But anything for now?
Are you still going to be doing office hours tomorrow?
Yes, I will be in my office hours tomorrow.
Okay, thank you.
Cool. Well, I'll stick around. So if anyone wants to stick around and has any questions about homeworks or want me to go over anything, let me know. Otherwise, I hope you have a great rest of your week, and I hope you have a good weekend. As I've continually said, work on things over time. We're almost at the end. So I hope your end goes well and your semester goes well. And please don't hesitate to reach out to me if you need anything at all. Thank you all.
Professor.
Thank you, Professor.